is Alessandro Marcone. I'm a senior research associate at the University of Alberta's Health Law Institute, housed in the Faculty of Law, and I'll be moderating the session today. Before starting, I'd like to acknowledge that the University of Alberta is located on Treaty 6 territory, and it respects the histories, languages, cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. As I myself am currently located in Ottawa, I'd like to recognize that I'm living and working on the territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. The Alberta Transplant Institute would like to thank Paladin for the continued and generous support of this speaker series. And today's session, as you've likely seen, is titled The Intersection of Transplantation Ethics and Medical Assistance in Dying. As many here are likely aware, medical assistance in dying, or MAiD, was legalized in Canada in 2016. And while I think you'd be hard-pressed to find extensive criticism on the existence of MAiD, numerous concerns have been raised since its implementation relating to both overarching principles as well as corresponding program logistics. And that brings us to the speakers today, who are going to be discussing MAiD in the context of donation and transplantation. It should be a very thought-provoking session with some practical implications, and I'm really looking forward to hearing from and discussing with our invited speakers. So we have two speakers today. We have Dr. Brendan Leier. Brendan Leier is earned his PhD from the Department of Philosophy, University of Alberta in 2002. He's an adjunct professor with the John Dossiter Health Ethics Center. He's presently doing research on the topics of pediatric best interest, moral distress, end-of-life decision-making, transplant ethics, ethics of medical technology, compassion in the practice of medicine, risk, and decision-making. And he's joined by Dr. Cheryl Mack. Cheryl Mack, MD, is an anesthesiologist and pediatric palliative care specialist. Dr. Mack is the past chair of the Clinical Ethics for the Stollery Children's Hospital, the Mazankowski Alberta Heart Institute, WCM Health Science Center, and the K Edmonton Clinic. She has over 20 years of experience in clinical ethics, professional ethics, and organizational ethics. Her interests include supporting families facing complex medical journeys and the associated challenges with decision-making that often accompany these experiences. And some of her current areas of research include drug policy ethics, MAiD legislation implementation, moral distress, and healthcare worker well-being, as well as the ethics of advocacy. So just before I turn the floor over to our speakers, I should mention that we'll hold the questions until the end of the session. At that time, you can raise your hand, or you can if you prefer, you can leave your questions in the chat. But if a question comes to mind during the session, feel free to write it out in the chat, and we'll make sure that we'll bring it up at the end of the session. All right, and with that, I'll pass it over to our speakers.
Before we get started, I would also like to give a shout out to Dr. Nathan Gamble and thank him for being part of the early discussions around this presentation. We don't have any conflicts of interest to declare. Okay, for the objectives for this session. They will be to understand the ethical foundation for organ transplantation, recognize the tensions that arise when that practice intersects with MAiD, and appreciate the importance of continued advocacy for the potential donor and family experience through the palliative lens of caring. And really, what do I mean by that? Well, palliative care brings a holistic perspective to caring, addressing all the domains of suffering with an aim to maintain hope and quality of life within the limitations we all deal with as fragile human beings. We also open doors for vulnerable conversations around grief and existential concerns, and we care not just for the patient, but also for the family that is part of that journey. So some key points, and I got these from a qualitative systematic review by Zoo that was published in 2024. And they looked at the circumstances affecting patients' euthanasia or medical assisted suicide decisions. And they collected perspectives of patients, relatives, and healthcare professionals. So some of the key points from their scoping view is worldwide, cancer is the most frequent diagnosis associated with euthanasia or assisted suicide requests age 60 years or older. Debilitating illness and a short-term prognosis is a strong trigger for such requests. And in Canada, that would be our track 1 patients. Interestingly, pain was not a main reason. Rather, quality of life considerations played a major role. And this contrasts with our Carter versus Canada case, where pain was a central concern when that case was going to the Supreme Court. Intertwined with symptom management was the fear of loss of capacity for future MAiD decision-making. Some studies reported underutilization of meds for this reason. One study reported examples of physical symptoms being under control at the time of assisted death. So the suffering driving request really crosses many domains, and it's not just physical. It is subjective and a matter of degree with respect to the sort of impairment that suffering is causing. Irremediable in these situations could also be understood to be a loss of hope for the future and what that might look like. So specific for this talk is MAiD in the track 2 patients who are more likely to be the growing pool of potential donors as criteria expands. This population will continue to be controversial and a source of moral and professional concern. And why would that be? Well, this is the population where natural death is not reasonably foreseeable. Transplanters should be aware of the concerns and how that may impact practice. So now I'm going to turn it over to Brendan. And Brendan, don't forget to tell me when to switch slides.
You can switch slides, Cheryl. Thanks. So just some personal remarks. Cheryl and I have found ourselves in a very unusual situation philosophically as we started working on MAiD together. I think, I don't know, 2015 or 14 or something like that. Yep. And early on, we identified in 2016 in a publication a concern that was a very high level concern that physicians that in the way that physicians were being included first by the Supreme Court and then second by the federal legislation in the process of MAiD. And our criticism of the time was that the physicians had very little responsibility in developing criteria or identifying criteria, and many, if not any of their clinical skills and judgment were utilized in order to facilitate MAiD, and yet physicians were originally the only professionals allowed to provide MAiD. And so our argument at the time was that this is a curious decision, and it seemed that one of the things that physicians needed to watch out for was basically having their trust, meaning the society's trust in the medical profession, used as a commodity. So the paper was entitled "Brokering Trust," and I have to say, Cheryl, that what we talked about in that paper is equally, if not more, true now, and though none of our concerns have really been mitigated as the MAiD policy has become more sophisticated and gone through several iterations. So that's what I want to talk about now from a very broad perspective. I want to discuss the whole topic of ethics first, and try and insist that when we talk about the ethics of this or that, really, in reality, what I'm trying to do today is identify really the specific ethics of particular cultures. And in the talk today, the request was to describe basically the intersection of 3 different cultures, each of those cultures having their own unique code of ethics and set of ethical instructions. And this is an obvious challenge whenever you have cultures coming together and overlapping. It's in my particular romantic view, it's lovely to see, the intersection of human values and how richly they do intersect, but it's also interesting to see where they don't overlap, and how it's really one of the important considerations here is to ask yourself not what are the ethics of MAiD and transplant, but what role do I occupy in this, in my position, and what are my responsibilities in light of that role. So a lot of the transgressions that I would suggest come from people not occupying their role in this process, whether they be bureaucrats or physicians or advocates or whoever. So the other thing I want to point out is that really there is an underlying tension that MAiD and transplantation is an instantiation of, that is far older and far more concerning, and that really concerns the role of professions in this particular culture, and that this tension can be identified in in what Richard Taylor suggests really are the two major questions of ethics. The old question, we're talking about the time of the Hippocratic Oath was written, is what is the good life? And this is the only question that the Greeks really considered to be the ethical question. And it's specifically relevant, especially now, to professions, because the lineage of professions, especially medicine, come from that time. And so it should still, no matter whether you're a senior staff physician or a trainee, the question of what is a good physician or what is a good nurse should be always front and center in your mind. And that should be a question that you continue to ask through your entire practice and through your entire education in your life as a professional. So that's the old question, what is a good life? The new question, what makes right actions right? Is a sort of deliberation, a proposed set of rules that describe specific actions and their justification. So here you have the classic deontology and utilitarianism and things like that. And I want to suggest that if the tension I'm alluding to really is the erosion of the autonomy of the professions in the 21st century, and the sort of the old picture of where physicians are independent, they exist in a covenantal relationship with society, and the covenant is basically an exchange of trust and autonomy to professionals in exchange for being particular advocates. Now, the erosion I'm talking about is basically the transition from medicine as a profession to being a service provider, and that transition occurs when in a sort of liberal democracy, the question of the good life sort of disappears and is replaced by the ethos of material consumerism, right? Where the question of value is really only reduced to what do people want. And if you've ever taken a trip to Mexico, for instance, on a holiday and gone into a pharmacy, it's very clear what consumer healthcare looks like. You can go in and buy Lasix or anabolic steroids or whatever you want as you demand it, right? And so a lot of criticism, especially in the States now, that because you can appeal directly to subspecialists, somewhere if you want something, someone will do it for you. And an ethic of professionals would push very hard back against that. And so the tensions that occur in transplantation and MAiD in medicine are really reflective of this larger debate, larger process of the tensions of the erosion of professions. And if you ever want to look at a good example of this, look at the early MAiD proceedings in the Senate hearings and things like that. The way that politicians and lawyers were speaking about physicians was remarkably disrespectful, especially in that context. So I just want to touch on pull out a couple of the relevant aspects of the Hippocratic tradition that I think have to be sort of considered invariable and also essentially valuable. So the invention of the profession in the Hippocratic Oath is really the establishment of the domains of knowledge and practice, right? And here there are a couple of very interesting points. And they're interesting points because originally the Supreme Court identified the right of physicians to not perform or not participate in the process of MAiD, but they described that as a conscientious objection. And I think that was kind of a misnomer, as there are legitimate forms of conscientious objection that come, the historic ones, from pacifists and pacifistic religions who simply refuse to kill on principle as a matter of value and of their appeal to conscience. But here in the Hippocratic Oath, we see an expression that physicians shouldn't participate in killing their patients. In this line that says, "Neither will I administer a poison to anyone when asked to do so, nor will I suggest such a course." But as this continues, the thought continues. They also say, "I will not use the knife, nor even verily on sufferers from stone, but I will give place to such as are craftsmen therein." And so here the oath isn't saying physicians can't kill as a matter of some kind of overarching objective moral principle. They're carving out a role and saying what is inherent, what is the relationship between healing someone and killing them is so inherently a conflict of interest that physicians have to abstain from one of those, right? It didn't say people should not be killed. In the same, and the analogy that they give is a really revealing one, because they also carve out a distinction between physicians and surgeons, right? And that's a distinction that a lot of people don't even appreciate now existed, but still in the UK, for instance, a generation ago, surgeons were not called doctor, right? They were called Mister, and they were very proud to make that distinction, and that distinction is sort of held up. So the question from the Hippocratic tradition, from the medical tradition, is a conscientious attentiveness to conflict of interest, and that is built in to the very essence of professionalism right from the start. So this is an ethical point about medicine from 2,000 years ago. Go ahead, Cheryl, please. The second essential aspect that survives from the Hippocratic tradition that is really the absolutely the most important is the establishment of the fiduciary relationship, right? And that means that's just a complicated word that basically says, for lack of a better term, as a physician, my fundamental moral obligation is to advocate for the best interest of my patient to the exclusion of all other interests. And this is really this. If you had to point to the sort of quintessential birth of professionalism, it is in the articulation of this relationship. And so we use the term professional, unfortunately, in a very broad sense now, basically to describe people who get paid to do what they do, professional YouTubers or baseball players or something like that. But the essence of professionalism is the fiduciary obligation. So lawyers, physicians, accountants all have fiduciary obligations that basically say, regardless of whatever else is going on, I need to advocate for the interest of my patient. Next slide. So the ethically relevant points to pull out of this: the prohibition of a physician on killing a patient is not a reflection of a broader moral judgment about killing, but rather the recognition of the conflict of interest inherent between the practice of healing and killing. Modern medicine has reflected similar distinctions and practices as well. So even in jurisdictions like, say, the United States, where capital punishment is still practiced, physicians and nurses, as a matter of professional judgment, have refused to participate in those practices, and actually sanctioned professionals who were participating in those practices, even though it was perfectly legal to do so. And the states often attempted to compel and even coerce medical teams in participating in capital punishment. Next slide. The other ethically relevant point: physicians steward a covenantal relationship with society, where interdependence and self-governance is exchanged for trustworthiness, expertise, and fidelity. And if you can't really emphasize this point enough, and it can be demonstrated. In different ways, anecdotally, all over the place. I remember there's an emergency physician named Jen Pritchard who worked with our ethics service for a while, and she went on a disaster relief to Pakistan one time, and she said they were very soon overwhelmed when people realized there were Western doctors in the region, and they were coming to get treated for tuberculosis and stuff like that. And Jen's understanding of this was that the physicians they currently had, who ordinarily provided medical care, simply were not fiduciaries, right? And they gave up medicines that they gave up inappropriate medicines, or treated people for the wrong reason, or refused to treat them. And it was the recognition simply that there were independent physicians existing in the territory caused people to be loaded into wheelbarrows and hauled over mountain passes and things like that. And Jen found that to be quite remarkable. And I always remember her telling me that, because I think it's just a beautiful example of the recognition of the importance of that independence and that advocacy. Next slide, please. So the way you can articulate this, the physician's fundamental moral obligation is to act in the best interest of the patient, to the exception of all other interests, including the physician's own interest or the patient's opinion. Now, this is very important, the patient's opinion, because when the Supreme Court made its decision, this canonical decision about MAiD, in the very first iteration of the legislation that came out, there was intentional and very problematic bit in that legislation that basically said that described the context of MAiD, and this time it was track one. They said people are MAiD candidates if they have irrevocable suffering and if no treatment is available, comma, that is acceptable to the patient. And just that simple line basically undermined a professional's professional judgment in the candidacy of MAiD patients. So, for instance, in this current track two, I might be able to go, or if I have treatment-resistant depression, and a secondary specialist is called in, who's a psychiatrist, say for instance, and said, "Well, I see here you've never tried ECT, which is the gold standard for clinical depression." If I say, no, that's not acceptable to me, I don't want to try ECT, then that's fine. And so the question of a candidacy is not a matter of fulfilling professional criteria as applied by a trained and specialized clinician. It is basically at that point much nearer to a consumer request. And so this is really the key, one of the key hinging points here that causes Cheryl and I concern, and that is although there's lots of referrals to clinicians and their judgments, and in the track two, there's even an inclusion of a specialist physician in there. The question is, what power do they actually have to exercise that judgment, and what's the meaningfulness of that judgment if patients have the right to refuse treatment as a matter of personal preference? Next slide, please. But what about autonomy, you say, Brendan? This one, many people are probably screaming this right now. Respect for patient autonomy becomes a defining issue in medical ethics in the 70s. And at the time, a patient's right to choose manifests its relevance as a moral principle in response to technology. So we have, let's say, for instance, finally the sort of the technological sophistication that we be able to keep people alive on ventilators. Okay. Now, the ethics of ventilation, the ethics of life-sustaining treatment only really kick in after that, because before this wasn't really a question, right? So the question of autonomy, and so you have people on ventilators in the 70s, and very famous cases that, in the United States and Canada, where people say, I don't want to be in a ventilator anymore if I'm not going to ever be able to come off. And their physicians said, well, we're not going to kill you. We can't kill you. And so these cases had to go to court. And of course, the principle of autonomy was rightfully evoked and said, no one has the right to do anything to you that you don't want done to you if you have capacity to make that decision. And secondly, even more important, you don't have to give a reason, right? The expression of your the expression of the will not wanting to be harmed or not wanting to be interfered with is in Canada one of the most fundamental elements of patients' rights, right? And so autonomy was interpreted, the early cases of autonomy were interpreted as cases where you have the right to say no. MAiD has a sort of flipped around the other side, and is now sort of autonomy is interpreted as the right to demand treatment. Now, of course, these two considerations intersect when physicians have a right or have the obligation to act in your best interest, and they have to say, or they have to consider whether the request for MAiD is actually in the patient's best interest, in the same way that they would consider a request for IV or for an antibiotic prescription in a family physician clinic, right? We have the right, and physicians are encouraged to say no, and to not participate in activities they believe are harmful or non-therapeutic, and yet that obligation technically according to legislation, sort of disappears. They no longer have the right to say no. So the question, the question is then, how do you proceed as a fiduciary, conscientiously as a physician, and as a MAiD provider, if you lack the sort of ability to say no, and are sort of encouraged to acquiesce to these requests? So this is a sort of ongoing tension that will always exist, and really, the devil is very much in the details. Okay, okay, next slide. I think, Cheryl, we can hand over to you.
Really? Okay, let me just.
Okay, so this last slide basically says that the principles that guide medical decision making are fundamentally teleological. Every single decision should have a rationale, and not only have a rationale, but should be transparent. So I always say in a clinical structure, any single person should have on a team should have the right to say, why are we doing this, right? What is the reason that we are doing this specific thing to this specific patient? And staff physicians or people who are at the top of these hierarchical structures should welcome that. They should welcome the opportunity to explain and justify the rationale for treatment. And this is, again, another one of the essential aspects of professionalism. And in addition to that, it should also include decisions that are clinically ethically grounded, particularly in the principles of ethical principles like proportionality, which says if we are attempting to a treatment that has an inherent harm, then this treatment has to be justified with at least a proportionate theoretical outcome. Now, the things might not work out well, but at least theoretically, there should be a justification of how this treatment is going to be proportionately more beneficial than it is harmful. And that inherently should give you a justification to avoid doing things to patients that we all agree shouldn't be done at the request of families. Maybe there's many examples of that. Okay, let's continue on. So transplantation so the ethics of transplantation then, transplantation as medical technology has demonstrated clearly the truism that medical ethics chases technology. So transplantation occurs before transplantation ethics. And after transplantation was demonstrated in living donors as a viable therapeutic technology, new ethical challenges were immediately identified. So for instance, the namesake of our center, John Dossiter, was a nephrologist here at the University Hospital. And as soon as they started doing renal transplant, Dossiter recognized that the ethical challenge here is that we have this very scarce resource, these cadaveric kidneys, and the potential candidates to receive these are vastly outnumbered. And so we need to have a methodical and transparent process. So the decision of who gets kidneys of all of these candidates require kidneys and that are sort of living on dialysis at the time isn't a decision made behind closed doors, with powerful advocates and a secretive process. So Dossiter starts the U of A ethics committee, and the committee then, at the time, the sole function was to deliberate over the process of allocating these scarce resources. So transplantation ethics then is uniquely crossed over with the Hippocratic tradition, and is far more concerned at a systemic level with questions like resource allocation and rationale to provide. So one of the ongoing, next slide, please, Cheryl. Of course, one of the ongoing, next slide, please. So the emergent issues in transplantation then became what obligations do people have to stay on life support, right? And so this was kind of a cultural, theological combination of clinical practice. And the early direction, let's say from the Catholic Church, was, well, as a Catholic, you have to accept ordinary care. It's wrong to stop eating, say, for instance, to kill yourself, but you have the right to push back against what they called extraordinary care at the time. And instead, this language was changed from proportionate to disproportionate, right? So for instance, if you being on life support caused a disproportionate burden to you yourself or to your family, you had every right to say no to it, right? And so so this described basically this sort of this complex network of sick people who were potentially organ donors at the time and what their rationale might be and their justification. The scarcity of resources, of course, cadaveric organs requires sharing sometimes across very large geographic situations. We have the emergent issue of brain death when critical care became good enough to basically sustain people's physiological function, even in the event of catastrophic brain injuries. The concept of brain death as a clinical prognosis and diagnosis allowed for organ transplantation in livers and hearts, which otherwise couldn't have been done typically in the old fashion of organ procurement, right? Donation after cardiocirculatory death, of course, is an innovation in transplantation. It was one of my very first tasks as a clinical ethicist was to become involved in this discussion. And I remember getting this email chain and reading these emails about DCD, and the email chain was so vitriolic. It was really remarkable that they're having such a candid and straightforward discussion about implementing the process of DCD, what safeguards were in place. And we basically, I think it was Rex Townsend ultimately at this site oversaw the establishment of DCD and the determination of death in DCD. And then, of course, NRP and ex vivo are technologies that are again posing new challenges to the sophistication of transplant ethics. So ethically relevant points here, the dead donor rule has always been a fundamental rule in transplantation that says the procurement of organs from organ donors cannot be the proximate cause of their death, okay? And so the dead donor rule is still an inviolable rule. And even if the secondary MAiD candidates or track 2 candidates will become donors, the procurement of organs will not cause their death, right? So there will always be an intermediary step. So transplanters in harvesting organs are not the immediate cause of the donor's death, right? And I can't imagine the dead donor rule is not the most practical rule, but I actually can't see it going away. There are lots of people who argue that the dead donor rule should go away. Myself personally, I would have absolutely no qualms if I had ALS or something like that to give all my organs and have the donation being the proximal cause. But it is ultimately the recognition of the importance of the mitigation of conflict of interest that the dead donor rule, I think, will always sort of be around in some respect. Other ethically relevant points, transparency in process, the minimization of conflict of interest and the demonstration of that has always been central. And then the culture of transplant has a very unique ethos that revolves around the consideration of organ donation as a gift, right? And of course, that in order to pay heed to that and recognize that as a sort of canonical metaphor that guides the ethos of transplant, the maintenance of trust or stewardship is absolutely essential. So it can never be seen that transplanters or transplant services are harming donors or undermining donors' best interests in order to receive organs. And the gift aspect really practically for me, it sounds here like a nice metaphor, but the meaningfulness really comes in the practicalities of transplant and the anecdotal circumstances that Cheryl and I have seen over the years every single leap forward in transplantation at the U of A site has come at the request of a family who have been either organ recipients or their family members have been organ recipients, and they are transplant families. And they will say, we want this done. So the very first DCD, there was no policy before it happened. It happened at the insistence of a nurse who had been an organ recipient, or the family of a nurse who had been an organ recipient. And it's these families who are in the sort of transplant community that have always been the most vehement advocates for progress like this. And really, we've responded over time in response to these types of requests. So the idea that that donation is a gift, and of course, gift giving invokes, as Marcel Mauss, I hate to refer to sociologists and give them credit for anything as a philosopher, but Marcel Mauss identified this in the 1800s, that the meaningfulness cross-culturally of a gift is to invoke reciprocity. So the reciprocity for families, the reciprocity to families, and to steward the process of transplantation is absolutely key and one of the most fundamental values in transplant. And there are many anecdotal situations that you can point to. In Germany, for instance, there was a transplanter who was accused of hastening the death of a donor, and after that, DCD wasn't allowed in the entire country, and still may not be allowed in Germany. I haven't checked in the last couple of years, but that is how critical it is to maintain the trust in the process, because trust building occurs very slowly over time. Trust destroying events are anecdotal and are typically catastrophic. So the stewardship is the thing that really I want to focus on, and I think that Cheryl's going to re-emphasize going forward.
Okay. Really what I want to focus on is this area of overlapping concerns with MAiD and organ transplantation. There are concerns, I think, that are consistent between groups of stakeholders, and these shared concerns should be helping inform how we proceed. Now, I can't cover all of these, obviously, but I will highlight a few that are relevant to the audience and to organ transplantation. Now, the professional concern I want to highlight is the role of the physician in assessing requests. This was alluded to by Brendan, and I think it does need re-emphasis. So the support for MAiD is both autonomy-based and harm reduction-based. But autonomy is not the sole moral principle that guides medical judgment. We bring in a whole lot of other medical principles to help us arrive at a decision. And all of these principles are critical in and also consistent with a harm reduction approach. But when doctors raise concerns and appeal to these principles, we're often criticized as paternalistic. Yet our moral and professional obligations are not trivial, as Brendan said. There are good reasons why we are cautioned to carefully consider proportionality when making decisions when both harms and benefits are playing a role. And the transplanters in this audience will certainly recognize that other moral principles play a role in, for example, recipient selection. Autonomy is a key moral principle to respect, but it's not the only one we weigh. So, for example, what is the role for medical judgment when irremediability of suffering is a key criteria for MAiD? What if the irremediability of suffering is external to the patient? How should we respond? In a Canadian context, we've had a couple of recent cases that made the news, Sophia and MV. Now, Sophia, for those of you who don't know, was a patient diagnosed with multiple chemical sensitivity, and she did meet the eligibility for track 2 in MAiD. But she also stated she did not want to die and would decline MAiD if she could obtain housing that was modified to accommodate her chemical sensitivities. But after 2 years of frustration and lost hope, she received MAiD in February of 2022. And recently here in Alberta, we had the case of MV, a patient with autism spectrum disorder, where only one of 2 physician assessors denied the application, and a third physician was brought in and approved the application. That case went to court because the doctor had concerns about the objectivity of the third doctor. And when talking about ASD, like autism spectrum disorder, we can learn from a review published by Tufree and Wine in 2023, which is also included in the slide on references. They looked at 39 Dutch cases. And the reasons for the euthanasia requests included social isolation and loneliness in 77% of the cases, lack of resilience or coping strategies in 56%, lack of flexibility, rigid thinking, or difficulty adapting to change in 44%, and oversensitivity to stimuli in 26%. The author was not arguing with the fact that the patients were suffering. She, in fact, stated she had no doubt they were. But the author asked all of us to consider in this review, is there truly no other way to help them? So the vulnerability may originate with the patient, but the suffering is exacerbated and or made intolerable by the choices of others or societal circumstances. The question then becomes, is MAiD truly harm reduction and enhancing autonomy in these cases? So what should our response be to help the next Sophia or MV? Is there anything we can do? What as a profession should be our response to those sorts of cases? It is important to point out that these cases are very different from Carter versus Canada, the case that prompted the Canadian MAiD legislation. When suffering is a direct result of the medical condition and we have run out of reasonable options for the patient, then prioritizing autonomy can be viewed as harm reduction. So how should we respond if the source of suffering is arguably external, unjust characteristics or practices of society? In a 2021 annual report on MAiD, 99.2% of the applicants satisfied the intolerable suffering criterion. The subjectivity of suffering is not what we are debating, and it's not to be ignored. It's very critical. But how much room is there, as Brendan said before, for medical judgment in MAiD? And what if the conclusion is, and it might be, that there's no room for medical judgment in MAiD? That's an important question for medical professionals and their role in MAiD. And society and the profession will need to have a fulsome discussion around this question as the criteria expands. Now, more explicitly bringing in the perspectives of other stakeholders, the family and patient perspectives, is especially track 2, is a qualitative study out of Ontario that used semi-structured interviews of patients with mental illness and their family members. 6 themes were developed from that narrative, and that included raising MAiD awareness amongst the patient population, sensitive introduction of MAiD and goals of care discussions, asking for MAiD, a very person-centered and focused response from the professionals involved, a comprehensive circle of MAiD care, a holistic person-centered assessment process, and the need for support in the aftermath of the decision. Family and patient perspectives on the implementation of MAiD offer important considerations for emerging practice standards. I'm going to focus on the 5th theme today and highlight the 6th as we discuss transplant concerns. This paper begins to flesh out the important palliative philosophy of care aspect that we need to consider when patients start exploring MAiD. So an overarching theme that emerged was that MAiD is not a treatment but a last resort. Healthcare providers should still engage with multidisciplinary supports and still focus on making their lives livable while they're going through this exploration of MAiD. Patients in this study are still relying on physicians to exercise judgment and take a holistic approach towards suffering and the possibility of its alleviation. Such an approach is best achieved with less siloing of the MAiD process from the healthcare providers who know and are trusted by the patient and family. There is likely a fair bit of vulnerability and uncertainty in the patient bringing up a conversation about MAiD. And so in having these conversations, we need to be compassionate, not judgmental, trauma-informed. That's all critical. These conversations open up opportunities as well that can't be missed for an authentic exploration of suffering and hope for its alleviation. This is bringing the palliative lens into these conversations and is key to supporting a patient and a family. Now, turning to this transplant stakeholders, I relied on a 2-part 2024 scoping review on organ donation in MAiD and try to highlight some of their key points. The first cases of organ donation we already know happened in 2005 in Belgium, 2012 in Netherlands, and actually quite quickly in Canada after the legislation 2016. All 3 countries have published protocols and guidelines for euthanasia and organ donation. Both Belgium and Netherlands have follow-up review processes for instances of organ donation and euthanasia. The authors of the scoping review could not find evidence of similar processes in Canada. In the scoping review, 75 out of the 121 included articles mentioned ethical concerns, and here's a list of them: safeguards for organ donation, eligibility criteria, disclosure of information between donors and recipients, directed organ donation, death determination, organ donation, and death by donation. The ethical safeguards is what I want to just highlight for today, and that is the separation of the MAiD and the organ donation decision, the freedom to withdraw consent from either at any stage. And the reason for these is the fear of coercion or motivation of a decision to get made because of organ donation interests. So organ donation must remain secondary to the MAiD process. How does this look in Canada? Well, it varies by province. Some provinces recommend that all patients who request MAiD are approached and informed about the possibility of organ donation, while in other provinces, patients are not asked about organ donation unless they start the conversation. For this final part of my talk, I just want to reflect back to stewardship. The donor and family experiences through this entire process is a primary concern. Donation can be a measure of comfort for all involved, and these are patients and families taking their grief and turning it outwards into hope for others. Key to organ donation is the reciprocity we've talked about. It's the care we show to each other. As stewards of organ donation, transplanters should be concerned if track 2 patients are not having their suffering addressed to the best of our abilities. We all should be concerned about modifiable external factors playing a role in the loss of hope for these patients and families. And we need to learn from cases like Sophia and MV and ask how we can better support members of our community who are struggling. In talking to family members of donors from our opioid crisis, we are taught that families of donors feel anguish when there is a lack of caring. This impacts their relationship with the donation process. It impacts their grief. The need to support in the aftermath of the decision-making was brought up in the study on MAiD and mental illness. Regardless whether family members are included or not in the MAiD discussion, and often they are not, they may have conflicting emotions about the decision. When the donation is also part of the process, this adds another level of complexity and also overlaps with this idea of stewardship of the gift giving that is of concern for transplanters. We need to ensure they have adequate supports to help them through a very complicated grief process, and that's just one aspect of the care considerations that will need attention. And just finally, to finish up my talk, I want to emphasize this point again. It can't be emphasized enough. In order to steward your own transplant service, advocacy for patient populations seeking MAiD and safeguards for their continued care throughout that journey, however that ends up, is part of your fiduciary role. And now I'm going to turn it over to Brendan.
So I want to wrap up very quickly here because we need to, Cheryl and I really wanted to field questions. So key takeaways: not all ethical conflicts are avoidable or necessarily bad. Conflicts in transplant will arise from stakeholders exercising their own moral obligations. Especially in pediatrics, this is a small world. You could have a family and a patient who is a potential donor, and a family and a patient who are potential recipients that are in the same ward. Their families could be sitting together in the waiting room of a critical care unit like the Stollery. And so advocacy for patients to receive organs and administrators, for instance, who have obligations to oversee a process, a transparent, agreed upon process, might cause conflict, but those conflicts are good conflicts. Conflicts that come out of people staying in their own lane and occupying their role ethically are not bad conflicts. They're a demonstration that there are checks and balances. The stewardship of the ethos of transplant is a fundamental obligation, and I referred to that earlier, and that transplant requires interdisciplinarity and integration of all stakeholders. And I think we've wrapped it up now. Is there another slide? I don't think there is, Cheryl.
No, we just have questions, and I'm just going to pop up the references slide to make sure that it gets recorded so that people can look up some of the articles I've referred to. But yeah, we're open for questions.
What would be, if we had some policymakers or some decision makers who are either in the call today or going to watch the video on YouTube, what would you suggest are some very important next steps that some of these policymakers can make? towards addressing some of the, not to distill everything that you've mentioned down to one key step, but what would some key steps be for policymakers or decision makers?
I would say bona fide representation from key stakeholders in any. I would argue that not enough care and attention has been paid to representation on from Senate hearings to expert panels identified by the government to the Canadian Blood Services. The representation, apart from on paper, I don't think was legitimate. I don't think anyone who looked at those panels was legitimate. So having processes to have clear representation where you don't have advocates for MAiD across the board or advocates for transplant across the board, but you have people who can identify these conceptual problems. Because if there's conceptual problems at the start, like Cheryl and I have suggested, then ultimately the providers and transplanters are going to inherit those problems, and there's no way to mitigate them along the way. So that would be my recommendation, to have transparency built into the process from the very start.
Yeah, I would agree. I think like we need to, like I said, we're not all like islands of concerns. There is overlapping concerns, I think, within all the stakeholders. I think that's our starting point and that wasn't our starting point, right? Like we need to really listen broadly to, especially track two, the track two group as it gets expanded. I think everybody has concerns. Families have concerns. Obviously, patients also have concerns. They want to have a choice, but they also want as well to make sure that they've, been given options, right? Because really autonomy is choice. And if you don't have options, what is our role as physicians in these discussions? It's hopefully to make sure that we've covered all of our bases and that we've given them every opportunity to have hope, right? And so starting from that overlapping part of the Venn diagram would be I think a good start, right? Getting the concerns, coming together and actually dealing with them in a very authentic, honest way. And it might be uncomfortable and there'll be compromises, but at least we've had those discussions and we haven't felt left out, right? So I think that's important.
Great, thank you very much.
I just read Eric's question, and I really want to get to that. I think it's an excellent question, if that's okay. Do you want to read it, Alessandro?
Yeah, sure. We'll take that question and then we'll go to Tim up here, who also has his hands raised up. Can you comment on the ethical considerations around recipients being aware of donors having participated in assisted death? Is there a right to know? Are there privacy concerns related to the donor's choices? Is there a right to accept or refuse a donated organ based on the donor's choices?
So that's an excellent question. Yeah. That actually came up in the scoping review, which I would recommend everybody read those two scoping reviews because I think they're both very well done and they're in that slide. I guess, the question is, first of all, what's our usual practice about recipient and donors, right? And why would we change that? And if we are changing that, we have to have, like, again, sound reasons for why we're doing that. I think, again, what came up in the scoping review was concerns that some recipients would have concerns, moral concerns, faith-based concerns about the nature of how the organ was harvested. But also, is that something we often provide to recipient families? I think we really have to think about what information do we normally share and why are we stepping outside of our normal boundaries and have a good argument for that. And I can't give you that answer, but I think that's an excellent question because these are the things that actually came up in the scoping review as real, true ethical considerations.
Yeah.
And need to be addressed, right?
And you can't even judge the reasons. You can't even really judge the reasons because they're insidious reasons. Like I wouldn't want to receive an organ from a Black person, say for instance, but they're perfectly legitimate reasons. So I wouldn't go to China to have a liver transplant because I know that some political prisoner would be executed when I touch down, right? I wouldn't take a kidney donation from someone who I know had MAiD because they couldn't get palliative care in prison. But that should be my right as a recipient, to exercise my own conscience about these things. But the range of reasons is very interesting. So I think I can't think of a really good argument about lack of transparency about these things, to be honest. because that's a serious, you know, you can't, some of the reasons are vacuous and insidious, but some of the reasons are like the purest form of the demonstration of conscience of an individual. Mm-hmm. So not being able to empower people to make those decisions, I think is important.
I guess the thing is that if you're going to make changes to what kind of information is shared, one, of course, you need consent. But the other thing is, then why are we going to treat all the populations similarly? All your donor populations, right? Mm-hmm. And I guess that's a question for the people involved in that care to make, because I'm not that person that makes those decisions about what information is shared. But you have to have good sound framework, and it has to be something that you can point to and support for all of the patients, all of your organ donors and their families, right? And all of your recipients.
Just to be just conscious of time here, I would like to get to Tim up here in the top left corner. So Tim, would you like to ask your question to our speakers?
Sure, thanks. I'm an emergency doctor and a MAiD provider. So I've had conversations both about organ donation and MAiD. I'm sort of new to the MAiD process, and so far in the mentorship and in fact in the curriculum, so the Canadian Association of MAiD Providers has like a national online curriculum. It hasn't even mentioned organ donation. So I'm wondering, is that surprising to you? Is that something we should be trying to focus on more in the MAiD program in Alberta?
I find that interesting, okay, because I'm not a MAiD provider, so I find it is interesting that's not mentioned in your curriculum. There is, like I said, because there's policies and processes around organ donation and MAiD in Canada. Now, I know Ontario has some, and I think BC has some. I haven't, in that scoping review, they didn't have one for Alberta, but this is a national curriculum. So one would think there'd be some training around that. I mean, do you know, for example, Tim, in our province, whether how organ donation can be brought up with a MAiD patient?
I don't know.
Yeah, I think that's a big gap. Again, and I think that highlights how we haven't been really engaged in maybe even developing the curriculum as well, right?
Yeah.
Things that
now,
kind of conversations.
As I said, I'm new, so that it may exist and I've just missed it, right? But yeah, it is interesting.
Okay, I see it's provided to the MAiD coordinator. So I think it's really, and again, you know, these conversations aren't linear, right? Like, you know this, Tim, people bring up things and it goes off in different directions. I've had patients bring up MAiD in palliative care conversations and organ donation in the same conversation, right? And so these conversations aren't linear. So I think we do need to be very clear on what the direction is from our policymakers in each province, because it is variable, right? And we need to know what is the standard for our province.
Yeah. The very first time this came up clinically for us at the Mazankowski, a concern that we articulated earlier happened, which was that ethics is chasing technology. So I think there was a guy up north who was going to have MAiD and expressed his interest in being an organ donor, and the entire organization sort of flip-flopped to facilitate this, and it didn't ultimately end up happening, but the willingness was there to push the process through without those kinds of guidelines. So these are essential conversations to have before, in the middle of the night, you have to deal with the patient requesting MAiD and trying to wrap that on top of transplant. And my concern is that when track 2 patients, my ultimate concern is that as someone who's filled out the forms, the MAiD forms for a personal friend, my concern is that the intuitive ickiness of many track 2 patients are actually going to undermine the MAiD process as a whole. That otherwise MAiD providers like yourself who haven't anticipated track 2 patients will say, I'm fine with this, my head and neck cancer patient, but someone who is a teenager who's suffering from depression and someone who's fulfilled those criteria, maybe I'm not comfortable with that. And so my concern is that if you don't work these things out ahead of time, it's going to have a very severely negative impact on MAiD provision across the board.